unmet needs of the current biological treatment. The lack or loss of efficacy, safety issues, which include infections, infusion reactions. During one of our group discussion, we had a very interesting discussion on malignancy and the problem with biologics in patients with a previous malignancy, contraindication, and lack of oral administration that is preferred by some patients, and immunogenicity, which is a great issues in rheumatology, but also in dermatology. This is a proportion of the immunogenicity of biologics according to the SPC. So these are clinical trial data, not real practice data. And generally speaking, monoclonal antibodies have a higher proportion of immunogenicity rate if compared, for instance, with etanercept. Yesterday, Professor Mies discussed brilliantly the immunopathogenesis of psoriasis, which follow a sequence of cellular events. And the better we know the pathogenesis of psoriasis, the better we can provide treatment for the patient and developing new treatments. Concerning one of the most important cytokine players now we know in the talk between dendritic cells and keratinocytes, we are considering IL-22, which is released by Th22 cells. And also very important, I will discuss this a lot later, are the Th17 cells, which release IL-17, IL-18, IL-2, TNF-alpha, and interferon gamma. This slide summarizes for you the evolution of psoriasis treatment, therapeutic target evolution. We had small molecule drugs such as methotrexate and cyclosporine, and the target for this drug are inflammatory cells, keratinocytes, and immune cells, lymphocytes. Then we have the large biotech molecular drug, for instance, biologics anti-TNF, but that are already on the market. We have ustekinumab, anti-P40, but they are developing also large biotech molecular drug against IL-17, IL-23, you see in red, because they are in advanced phase of clinical development, and there are also in white speculative other potential targets for future treatments, which include, for instance, camerin. Camerin, I think, is an important potential target because it's an important bridge between metabolism, obesity, and psoriatic inflammation, because camerin is a recruitment factor for plasmacytoid dendritic cell in the pre-psoriatic skin. Then we will have also small molecule drug, for instance, tofacitinib and apremilast, which are for oral administration. Tofacitinib is also for topical administration, and they target signal transduction pathways, for instance, JAK2/3 for tofacitinib and phosphodiesterase ACE4 for apremilast. So these are the therapies in development for psoriasis. I accessed to the clinicaltrials.gov for having this data, and they include the IL-17 pathway inhibitors, which target IL-17, particularly secukinumab, which is a fully human monoclonal antibody and is sponsored by Novartis. Then we have ixekizumab, which is a target the IL-17A, is a humanized monoclonal antibodies and is sponsored by Eli Lilly. And then we have brodalumab, which is an anti-receptor, so a broad action on IL-17, and is a fully human monoclonal antibody sponsored by Amgen. And then we have MK3222, which target the P90 subunit, is a humanized monoclonal antibody sponsored by Merck. Then we have the small molecule therapies, as I said before, that target the JAK pathway inhibitor, particularly JAK3, is tofacitinib, sponsored by Pfizer, is a small molecule for topical, as I said before, and oral. Then apremilast, a phosphodiesterase E4 inhibitor, and also other small molecule targeting other target. It's very important, as I said before, to consider this target population Th17 cells, which release IL-17, mainly IL-17, but not only IL-17, and they are very relevant for the immune defense against extracellular pathogen. And IL-17 has an effector activity on cells of multiple lineages, including keratinocytes, and they stimulate on keratinocytes the release of IL-17, and they release other chemokines, but also they induce proliferation in keratinocytes. But IL-17 has other target cells, for instance, osteoblasts, osteoclasts, chondrocytes. So there is also a rationale for its targeting in psoriasis, psoriatic arthritis, and other arthritis. IL-17 acts on keratinocytes, and this, as I said before, stimulate proliferation of keratinocytes. So we have acanthosis, but moreover, keratinocytes release pro-inflammatory cytokines and chemokines that create a loop which activate again innate and adaptive immunity. So the potential role for IL-17 pathogenesis of psoriasis is complex. Surely it acts on not only on keratinocytes, but also on dendritic cell, macrophages, fibroblasts, and endothelial cells. And the action on keratinocytes in the hand result in the increased recruitment of myeloid dendritic cells and Th17 cells, recruitment of neutrophils in the psoriatic skin, stimulate the release of antimicrobial peptides, which are a stimulus for the immune responses, and reduce the production of filaggrin, so it disrupts the skin barrier, and as I said before, stimulate the release by macrophages, dendritic cells, endothelial cells of IL-6, TNF-alpha, and IL-1. So the potential role is complex and the functions are many. So IL-17 is a rational target for direct inhibition, and there is an important difference comparing IL-17 inhibition to the TNF inhibition, and is that with the inhibition of TNF-alpha, we are active on innate immunity and also on adaptive immunity, whereas inhibition, the IL-17, acting mainly on adaptive immunity. And the target is a very more selective target compared to the inhibition of TNF-alpha. So, which are the drugs? As I said before, the drug is secukinumab, brodalumab, and ixekizumab. You can see the differences. One of the most important is that brodalumab is an anti-receptor, not only anti-interleukin. And the other important difference is that the clinical development phase of secukinumab is advanced if compared with brodalumab and ixekizumab. Secukinumab is being developing psoriasis, psoriatic arthritis, ankylosing spondylitis, rheumatoid arthritis, asthma, and multiple sclerosis. So a huge clinical development phase. And these are the studies regarding secukinumab, because it's the first IL-17 target therapy with available phase 3 results. And there are placebo-controlled trial and for the induction phase study, and also for the maintenance trial. I will present you data on the erasure trial and the fixture trial, which is, I think, selected is because is a comparison with etanercept that is very interesting. And several aspects with important practical implication have been already addressed, including the efficacy of the drug in naive patient versus patient previously treated with anti-TNF, the efficacy on long term, 52 weeks, and as I said before, the comparison of etanercept. This is the design of the study, a ratio study design, which is 3 arms, placebo, and the 2 doses of secukinumab, 300 milligrams and 150 milligram. The dose that is being developing for the market is 300 milligrams monthly after an induction treatment. And this is a 52 weeks study. And these are the results. The PASI 75 response rate at week 16 is 80.1%. 86, yes, 86%. Thank you. You were listening. 86%. And for the dose of 300 milligrams, you can see that the curve is going down, but anyway, the proportion of patient approach to over 70% after 20 weeks of the study. And this is the investigator global assessment response 0, which means no psoriasis, or 1, which means mild psoriasis, is 73% at week 16. This is the other study, fixture study, and it's very important, the comparison with the 2 doses of secukinumab you saw before, and placebo, and also etanercept, and also is week 22 study, and these are the results. So the green line is the secukinumab 300 milligram, 77%, compared to 67%, and compared to 44% at week 12 of etanercept. So etanercept did very well, but secukinumab did better in comparison. And also for the PASI 90 score, we have a PASI 90 response in more than half of the patients, 54 patients in the 300 milligrams of secukinumab. And these are the data, the response rate throughout week 52, and you can see that the green line, tend to go down, slightly go down, but the PASI 75 response rate is over 70% after 52 weeks of the study. And we have a PASI 100 response in 37.36% of patients. Concerning the safety issues, the similar between etanercept and secukinumab. there were no differences, and the most common adverse event were infection, nasopharyngitis, headache, diarrhea, and arthralgia, and upper respiratory infection. So this is all for secukinumab. We have also the data, published data on the brodalumab on the New England Journal of Medicine by Kim Papp. We have at week 12 a response rate, PASI 75 response rate in 86% of patients for the high dose. And these are the data for ixekizumab. The response, PASI 75 response rate at week 20 is over 80% of the patient. So to end this part of the presentation, the IL-17 inhibitor seems to work very well on psoriasis and seems to maintain the response along up to week 22. The last part of the presentation regards the JAK inhibition pathway. The cytokine signal act throughout different pathways. One of these is the JAK, which is stimulated by IL-12, IL-23, IL-6, and interferons. There are different JAK combinations in the membrane of the cells, and we have that the binding, the cytokine binding of the JAK pathways activate the STAT, which activate transcription of several cytokine mediators in the nucleus of the cells. Tofacitinib can inhibit the JAK pathway. Binding to the JAK pathways inhibits the activation of STATs, and so stops the gene transcription and cytokine production. Tofacitinib is indicated for the treatment of adult patients with moderate to severely active rheumatoid arthritis who have an adequate response or intolerance to methotrexate. And this is the phase 2 study in psoriasis. Is a double-blind, placebo-controlled North American study, 4 arms, comparing different doses, 2 milligram, 5 milligram, 15 milligrams. The primary endpoint is at week 12, and these are the data, these are the results. We have a PASI 75 response rate in 67% of patients with the dose of 15 milligram twice a day. Oral administration. These are the picture of the clinical remission according to the different dosage. And this is the safety results. The most frequently reported adverse event plus of 5%, as you can see, is the diarrhea in the group of high dose, and also infection, nasopharyngitis, sinusitis, and upper respiratory tract infection, and then a signal of also headache. So in conclusion, which is the therapy of psoriasis in the future? I think that the personalized and stratified medicine is very important. We need to give the right drug to the right patient, and genetic biomarker of treatment response could be very helpful in helping us to select this kind of treatment. For instance, we know from that HLA-CW6 is a biomarker that predicts the response to ustekinumab in patients with psoriasis. Psoriasis is a ground for testing efficacy of new therapies in other diseases sharing similar pathways, and this could be the case for multiple sclerosis related to the IL-17 inhibitors. And I think that is a very important point to our practice, that dermatologists and rheumatologists also taking care of patients with psoriasis as a whole, like a family dermatologist doctor, including diagnosis and treatment of psoriatic arthritis, as well as preventing of metabolic syndrome and cardiovascular disease. Thank you for your attention.